Good afternoon, and thank you, Ibex, for this great partnership that we've had, and let's get going. We've coined the word welcome to our world. We've transformed or transitioned our practice starting back in 2018. And today's talk, as the founder and CEO of CorePlus, we really would like to share with you what has been our experience over these last years. One of the things that I really forgot was that a few months ago we were talking, and now we have celebrated our 5th anniversary of the transformation to digital and AI. And all of this would not have been possible without the incredible team that I lead at CorePlus. And obviously, you already know that Dr. Santa's here. My wife, Dr. Ramos, is here. And all the others. And I think Dr. Rivera is back there somewhere. And this couldn't happen without that great team. But I wanted to talk a little bit about cognitive revolution. And this is the way I see it. And I think that we have to think about history and how things change us over time. And I think the one that maybe we've lived through the most has been the second cognitive revolution, which was really the introduction for us of computing. And that really started to change how we saw information and how we managed information. And now we are right in the center of the next transformation, which is the transformation of AI, large language models, and now the development of agents. And I think some of the things that you just seen before are evidence of where we're going. So this was our call to action. I saw a press release from Ibex back in 2018 with UPMC. And when we founded CorePlus, CorePlus was focused on uropathology. So anything that came out that talked about uropathology, we wanted to be there. We wanted to be in the lead in that area. And the image behind you is an image of a company called Bioimaging that back in 2007, 2008, we had one of their first scanners. And it was really a very primitive scanner. All it did was count ER, PR, HER2, Ki67, and it was really the beginning and introduction to us in digital. So there was a gentleman by the name of Joseph Mosel that answered my email, that contact us on the website, and he answered it. I said, wow, he's interested. So our journey started in 2018. So we decided as a group and as an organization that our focus was going to be our primary objective for the next year was that by January 1st of 2020, we would transition or transform our histology practice to primary reads using digital pathology. So it took us a year to put it all together. We are lucky to have a sister company called Syndios, which is our technology arm, and that really helped us because instead of us having to go out and maybe purchase what was on the market at that time, we decided that we really wanted to have full control of our ecosystem because we saw, and we still see, huge changes in the marketplace, new innovations, and we wanted to be able to control our destiny. And so we did our validation. I think like all laboratorians, we all want to do our own validations. And I think the important data point here of all of them is the area under the curve. It came out at 0.991. So one of the things we wanted to know was cancer or no cancer. That was what we wanted. We wanted to implement 100% quality control of all of our prostate biopsies. It was a mission we wanted to do. We wanted to provide that to our patients and to our urologists. The second part, obviously, was looking at Gleason grading, and within the second read system or the quality control system, it was a little bit different. So we finalized the validation and we implemented and went live on June 1st of 2020. So every single prostate biopsy that came into our laboratory was analyzed by Ibex. So think about that. Here's a paper we published last year. If any of you are interested, just scan the QR code. Some of the data that I will be showing you, there might be information at the Ibex booth if you would like it. So this is our 3-year journey of using AI as a quality control tool. So some of the highlights from that paper was number one, looking at real-world implementation in a private pathology laboratory. So this was in academia. We're running a business. We got to get cases out. We're, doing it day to day. And how do we really take advantage of this tool? We wanted to, instead of doing a 10% quality review, we wanted to do 100%. How good are we? I think Mahul just showed us the difference between a 10% review versus a 100% review. So we wanted to do the 100% review. And on top of that, in private practice, how much time does a pathologist have to dedicate to really seeing consistently that 10% review? The other thing that we wanted to do was we wanted to have or eliminate the false negatives. I think for us, and again, as looking at it, and I see it from a business perspective, you have all of the pathologists before me that have tremendous experience, but how do I reduce my liability? How do I give patients better service? So we wanted to eliminate our false negatives. And lastly, we thought that this would normalize or democratize the ability of all of our pathologists to be good at diagnosing prostate cancer. So here we go. This is our 49-inch monitor that we use for all of our cases and throughout. One of the nice things about it is that we used it to deploy the second read, and this is how the quality control or second read system worked at that time. So we have the glass slides scanned, information is entered into the laboratory information system. The images are uploaded to the Ibex cloud. At the same time, the pathologist was diagnosing the case. Then we had a reconciliation, or we reviewed the alerts, and we emitted a quality controlled report. Now, that was extra work because now the pathologist has to wait to get the information back from Ibex in order to close the case. But that gave us that 100% quality control review that we wanted to. Another, in our laboratory, we have gone to doing 3 levels on one slide. Many years ago, we gave up the idea of having 3 slides with 3 levels, and our positivity rate did not change. So currently, we do that on all of our cases. And in the study, and the other thing is, you can see here is our positivity rate over time. Even though it has gone up, it's about 50% now. Obviously, patient selection criteria has changed over time by the urologist. I mean, there's many factors, so I don't want to say it's AI only. I think it's a lot of factors that have come into play as we get better patient selection and better technologies. But the one thing I want you to really think about is that in our study, over the last the the 3-year period that we did from June of 2020, June 1, to May of 2023, we analyzed 122,441 slides. That meant that the AI algorithm, there were 367,323 iterations of that algorithm. I don't know how much data more do we need. At least for us, that was convincing enough. And here are some of the results. I don't want to really bore you with this at this time, but basically these are the total number of cancer diagnoses. And one of the things that we developed of the 9,267 cases, we had revisions of 136 cases. And what we called it the AI impact, was when the pathologist did not diagnose the lesion and went back in review and the AI picked it up. So we called that the AI impact. And we also did the same thing for the Gleason grading, or ASAP to group 1. And that was just that group to whatever. I mean, there was no distinction in this version of the algorithm. And that was only 0.26. So here's what we call the AI impact. In our practice, we had 4 pathologists. And now you could see how their rate of detecting cases, or detecting the AI detected cases or lesions, where the pathologist did not. And so this is one area where I think it's very important, where we now are able to have more decrease the interoperator variability and have a very standard approach to all of our cases. So in May of 2023, we then implemented the current, what we call first read, which is what many of you see today. Much simpler, and it gives us a lot more efficiency. So I go back to my cognitive idea, and I think something to think about. But the one that the middle one, which is the AI-assisted workflow, it helps us. I think, as pathologists that are in this room, and like Dr. Thacker said, it's those negatives that bother you. You go home at night and you're thinking, did I miss something in that case? So this helps you. And the other area that I think is very important in today's world, where we're maybe short-staffed, we talk about the decrease in pathologists. That's been going around for years, and we're building more cases. I don't have that information 100%, but let's say it's true. How do we redistribute that energy in higher level thinking? So we call it cognitive fuel redistribution. So now, by using the first read application, which triages the cases for us, so we know which are the negatives, which have no label, the yellows, which are borderline cases, and obviously the reds are cancer. That now assists the pathologist as how they want to work. So maybe you want to do all of your yellows first, because maybe they require immunohistochemistry, get those into the process, and then whatever you like. You want to do your negatives or your positives, that's secondary, because you're going to do it very rapidly. And this is a poster session we presented at the DPA, Dr. Santa and the team. And here we show a 25% reduction in time for review. This is on top of the reduction in time because we are in a digital workflow. I don't think people have measured not just what AI brings to the table, but by transforming the practice to digital primary read has given us at least a 30% more efficient use of our pathologist time. So that's a combination of digital plus AI. So here are some of the thoughts I have. Number one, our negative predictive value. I think it's beyond doubt that when Ibex, and there's a doctor, and I don't know if his son is in this room today, Dr. Dario Sanabria, who says when Ibex says it's negative, it's negative. Don't waste any time. And I think in the future, you're just going to sign out those cases automatically. I know it's hearsay what I'm saying right now, but that's going to happen. So, number two, we have efficiency. 25% reduction in time to interpretation. And for us, it doesn't include all of the new things that we could be doing. I think some of the things that you just saw, they're going to make the pathologists even more efficient with reporting. You know, we're normalizing the variability among our pathologists. So we democratize the ability of, in this case, reading or interpreting prostate biopsies. In the marketplace, we have a competitive advantage. We're providing our patients with the latest and greatest tool, and obviously their urologist. Another important aspect today, recruitment and retention of our talent. Providing these tools are an important aspect of today's younger generation. They want to have these tools. They want to have work-life balance. They want to have the ability of being remote. We have, all of our pathologists have stations at their homes. They can read remotely. And some of them do on a weekly basis. They have days where they're remote, they're hybrid, and days where they're in the lab. Professional satisfaction. And when I say professional satisfaction, I'm not just talking about the pathologist. I'm talking about organization. The pride that we have by leading the way in the digital transformation. All of our team, everybody, is proud to work at CorePlus because of what we're doing and what we're doing on a national and international stage. They see what we're doing and they feel proud of us. So this technology helps us recruit, not just on the pathologist side, but overall. And lastly, I think, again, was brought up, the decrease in medical liability. Obviously, we haven't talked to our med mal carriers yet, but you know, is this something that we need to be looking at? Is there an area of opportunity here to reduce our med mal cost by bringing in AI? And maybe it's another way we look at it, a way of hitting that expense line. And lastly, where do you want to be? I think that you're going to be the information specialist of the future. I saw the other day also an interesting definition of a diagnostic oncologist. I think that you have to redefine who we are. What are we going to provide to our colleagues, to our patients? And we have the power, because we have the data, to lead the way. We can't no longer sit in the back. We have to be in the front. We have to sit with the patient. They have to know the value that we bring to the table. And our payers have to know the value that we bring to the table. Thank you very much.